Good afternoon. Thank you for joining our webinar today. Thank you if you're joining either via Teams or through the LinkedIn platform. As we go through the event, please do pop any questions in the chat and we'll try and answer. So good afternoon, I'm Shane Barry and I'm a concept advisor at Space Store Healthcare. And today I want to bring you a webinar to help share some insights and best practice through the healthcare work we've done and with the panelists we've got on today, to give a quick background to Space Store Healthcare before we jump into today's topic. So as a background, Space Store is a manufacturer of workplace furniture, and in our work within healthcare, we've seen a big change in the way healthcare is delivered, and particularly in the area of virtual consultations and changing the way we work and deliver healthcare. And we've learned from some of our engagement with some of the top leading clients we've worked with, such as Pfizer, Roche Diagnostics, and how can we help them drive their organizational goals through the work we've helped in their workplace design. And to jump into today's topic, we want to focus in on that and the sort of change we've seen in healthcare and how can we focus on being future-proof with the changes that are coming up. So today's topic is on transforming healthcare estates, creating a sustainable, flexible and future-proof design. So thanks again for those that are still joining. Just before we dive into our live panel discussion, I want to introduce all of us on the call today. So as I said, I'm Shane and I'm a concept advisor here at Space Store Healthcare. So my role typically revolves around helping our clients, whether that's the client themselves, so working with NHS trusts on how can we help on their transformation programs they're working with, or whether it's working with architects, designers on projects to help on their requirements using our products. So maybe Toby, over to you, if you could give a brief background to yourself, please. Thanks for joining today.
So good afternoon all. I'm Toby Banford. I'm a healthcare planner and I work at Arcus. So my interest is in capital planning, so the design of facilities and the built environment. So typically a lot of my work always involves working with clinical teams or client-side organisations, trying to determine what the brief is and then passing that over to the architects and the design team, say go away and design that. And so the outputs would often be schedules of accommodation, I call them PPDD, so policy, planning, design descriptions, or for those of us that are a little bit older, remember things like COS, clinical output specs, that sort of thing. And if I'm not doing that, I either sit with construction companies trying to interpret what other people have done. And I'm also a DQI assessor, so I get, as a design quality indicator assessor, I get to help the CIC, the Construction Industry Council, do gateway reviews and review other schemes that are coming through, and that's part of a prerequisite now. That's part of the business case process. So all I'd say is I can see a few people joining, and there's a few familiar names. So it's nice to see a few friendly faces, or friendly names, I should say. Thanks, Shane.
Good, thanks, Toby. And over to you, Alex.
Hi everyone. So nice to see everyone as well. I'm Alex Senchuk from Medical Architecture. I'm a senior architect and I've been involved in a number of healthcare projects over the past years, not only in the UK but also in places like France, over the pond in Canada, or other places like Morocco or Liberia. So I've been lucky to see a broad range of perspectives of how people approach healthcare. More recently, I've been focusing on strategic health planning aspects like demand and capacity modeling or schedules of accommodation. And we've been doing a number of business cases for the NHS Dorset ICB, as well as Dorset Healthcare, as well as more regional, let's say, estate strategy work for Midlands Partnership. Other than that, I'm also interested in planning integrated care systems. So at that level, I'm doing a PhD at UCL, looking at how clinical teams can collaborate with estates and business teams across organizational boundaries. So looking forward to today.
Excellent. Thank you, Alex. That's good. Over to you, Alex. Harvey.
Good. Thanks, Shane. And again, thanks to our panelists. Great to have you with us today. And thanks to everyone who's joined us virtually. So my name's Alex Harvey. My role at Space Store is focusing really on some of our global clients strategically and working with them in the implementation and kind of rolling out of their workplace strategy. So what we've seen in the last 2 to 3 years, driven by COVID and by the changes that happen, work from home and that kind of thing, is that many of the corporate clients we're working with here at Space Store are looking to develop the design of their workspace so the way that it's used to embrace hybrid working. Now that's different for every organization, but within Space Store, our kind of role in that is some of the modular furniture elements that can be used to divide or define workspace, whether that's individual spaces like this modular pod that I'm sitting in today, whether that's collaboration spaces. So working with our clients globally has been a big focus for me for the last few years, and by extension also working with some of our clients in the healthcare sector, whether that's the kind of office function in inverted commas where there maybe their admin teams and that kind of thing sit and work, or whether that's in some of the more operational areas. So excited to hear what our panelists have today, and also as we go through would welcome questions from all of you, from our audience, either via the chat box. You can see the Q&A box hopefully on the Teams window, and also if you're joining us on LinkedIn, feel free to use the Q&A box on LinkedIn Live. Thanks, Shane. Back over to you.
Good. Thanks, Alex. And yeah, echo that. Please drop them with questions and we'll try and bring some answers. So diving back to today's topic, today we want to focus on around transforming healthcare estates, whether that's existing or new, but focusing on a few points, but mainly around how can we make them flexible. So for the title we've put sustainable, flexible and future-proof design. And what we're really thinking here and our focus is the adaptability and flexibility are now some crucial factors within the healthcare design, and how can we maximize what we're doing to make sure that we are preparing ourselves for the future and effectively utilizing space, and still focusing on providing that patient-centered care, make sure we're not losing sight of that. So maybe to kick off, Alex S, if you want to just give us a brief intro into your thoughts around this initial topic.
Yeah, thanks, Shane. So I think the format for the conversation today is, we'll do less of a monologue and we'll do more of a collaborative discussion. So Toby, Shane, Alex, please interrupt me at any point. I'm just going to give a very brief intro and then over to you. And so please interrupt me whenever you think it's suitable. So I just wanted to start by just taking a bit of a step back and giving some context to this discussion today. So the way we plan things in the NHS, I think we can broadly talk about 3 communities. You have the clinicians, you have the estates teams, and you have the business communities. And the way we like to think about how we plan things, it's quite a linear process, right? So you start with the clinicians that develop a strategy and a model of care that gets passed on to the estates team, who have to design a building that responds to that need, and then it's passed on to the business team to develop the financing assessments around it. And usually what tends to happen is you find out it's unaffordable by the end of the process, right? We like to think about it in a linear way, but we know the reality is much more complicated than that, and it's definitely not linear. And there's lots of problems with that. But what I wanted to focus on today is sort of zoom in on a part of the process which is sort of uncommon, unusual to think about, and that is how innovation in the States can drive systemic change and can change the model of care. So it can change the way we deliver care at the system level. And within that, obviously, it's an approach similar to technology innovation. So when you're thinking about new types of surgeries, the impact of digital, that all has an impact on how we deliver care. And I think that estates can have the same kind of impact on the way we deliver care. So if you think about how we plan things traditionally, we have been planning things over the past 30 years. It's quite a cellular approach. So we're designing spaces and rooms that are just dedicated to a singular function. And what this means that you tend to have facilities that become obsolete sooner than they should be over time. So because they can only do one thing, it means that within 20 or 30 years, you need to replace that with something else because it's no longer suitable to host the activities that it needs to host.
Alex, I think you're spot on for me there, because it's over the years, and we've all seen it, and we do the brief, and it's often sometimes it can be really, it's quite specialty led, and we create spaces that are specific to certain departments, and that's fine. We've got to do that, but we also then start to say, but actually, what's the utilization of that space? And we often see that some spaces are quite low in utilization. I mean, I get that, and that's fine. And but you're actually paying for that space, so you're paying for that space not just as a capital thing, but also as a revenue consequence. And if we can start to think about, and I like to think we do try collectively, and I'm sure, and I can see a few other architectural colleagues on the call, but if we can start to think about that whole concept of adaptability and flexibility in the use of space, and I'm not one to get irate, but I say, do you know what? I really don't care what the name on the door is. Sometimes it's got a sink in it. I can put a couch in it. I can do certain things with it. Can I get maximum use out of that space during the working week? It's just fantastic. Sorry, mate, I just interrupted there, but I just think it's a really good point.
I think that's a really good point, and it sort of builds upon what I was starting to say.
Yeah.
I think it's a great point, and we're at this year we've seen the net zero carbon standard come out, which will become mandatory from October, won't it? And I think this standard is one of the key elements that will push us to think in this flexibility, adaptability, sort of long-term future-proofing terms. There's this very, very sort of clear diagram. I think it's in the very first pages where in the very first 10 years of the facility, you design it for something, and then after 10 years, you need to do some intervention on that facility to adapt it to that need after 10 years. So there's like a cycle that the facility goes through of continuous adaptation and improvement, and sort of aligning it with the latest model of care. That sort of we need to start thinking about. And
that's a classic one for me, Alex. This is the classic Toby quote of, I know what I know now, but I don't know what I don't know in years 7, 12, 14 and beyond. And it's that whole concept for me of saying, what was it? Dear architectural friends and colleagues, demonstrate to me how I change this in the future. And it's a fair and reasonable question. And I'm sure we'll come on to it a bit later on, but a lot of it comes through how we brief the space. It's if we can do a lot of this up front in the early days and in the early planning and get the brief right, get the space right, it's going to save us so much, if you like, A, capital costs, B, grief, and other problems later on down the line. So I think your point's really valid.
Yeah. So as architects, I think we would very much welcome a briefing or a process, or a client who would ask us, don't just do one layout of that facility. Can you do 3-4 variations of that layout so we can see how it could be adapted in the future? We would welcome to see seeing that. And it could be done quite fast. I think with the AI tools that we have today, we could sort of generate alternative layouts based from the core layout quite quickly. So I think it would be an interesting exercise in itself to kind of see what that facility is capable of long term.
Just latch on to Toby's point there, Alex, if I can butt in as well.
Yeah.
So what about the scenarios that we don't know about now. So, there may be new ways of working, or new technology, or new ways of kind of interacting with patients that the technology isn't here, and we don't even know what that's going to be. So how can we kind of bake in that level of flexibility into the way a space is designed or a building is designed?
Actually, I'm going to jump in there, Alex, if I may. So that's a really good example. So there are actually two examples I'll give you. One is we used to brief things like quiet rooms or interview rooms, and they could be like, what was it? In old money, it used to be 9 or 11 square meters. But if I actually took that space and actually briefed it at 16 square meters, that's exactly the same space as a consult exam room. So yes, it's a little bit bigger, but actually, do you know what? You've always got a ready-made consult exam room for the future, and it's taking tricks like that, and even in some of the new hospital program type stuff, and even in some of the other, if like modular construction things. Are we going to start working out in modules of 8, 16s, 24, 32s, that sort of thing? And you can do a lot with those. There'll always be, oh, let's do the 19 square meter single bedrooms and all that carry on. But there must be a lot we can do with, and I'm not, as many of my friends will say, I'm not an architect, and I leave it up to you guys. But there must be stuff we can do with grids that help us do all that. The other one, the last one, and I'll stop. It's so some of you might remember, what was it, intelligent hospitals that came out a few years ago. And one of the things that they started to challenge was to look at, and imaging is a really good example, where I might say to Alex, go and build me a plain X-ray room at, 33 square meters, build me a, CT room at 38.5, and build me a MRI at 44 square meters. But what would it be if we developed all the rooms at 44? I mean, that's adding space, but you could then change a CT to an MRI in the future. As we know, things will change. We could change an X. It's don't. I guess what I'm trying to say is always don't just get fixed up on maybe some of the really big items, and don't get fixed on the name of that space, but think about how we could use it differently in the future. So there are tricks and things that I think we can do that says, well, we can change things in the future. How do we make this truly adaptable?
Yeah, and if I can just add to that, I've seen someone in the comment section mentioning John Weeks. Yes,
yeah,
these principles are not new. John Weeks said it in 1973, which is like exactly 50 years ago. We need to design hospitals to be perpetually changing. So a lot of the principles we are talking about here are sort of basic principles, like having a standard grid, and working with modules, like Toby said. I would say one of probably the most important feature for future proofing that I would see is your floor to floor height or floor to ceiling height. So if you design something to save money and you lower the ceiling because you don't need, let's say, a 3-meter ceiling or whatever, you're automatically limiting yourself to just having certain types of spaces that would be suitable for that floor to ceiling height. So it's just one thing that you could change. And true, it does increase a bit the cost, but then it just makes the entire facility much more adaptable to a much wider range of functions.
And just out of interest, Alex, just on the last point you made there, there's often a cost associated with that flexibility.
Yeah.
And we all know that projects are always under scrutiny and budgets always tight. And sometimes that flexibility gets taken out as a kind of EE exercise during the projects. What experience have you got of kind of negotiating and engaging with stakeholders so that you retain that, you kind of retain that longer term vision, as well as the need of today's building that's got to operate in today's environment and within today's budget?
Yeah, that's a very good point. And I think that's one of the main issues that we're constantly dealing with. And I think Toby might want to pitch in here as well. I would say broadly, the way to negotiate is to show the benefits and to be able to quantify the benefits in the cost benefit analysis, if we can, which is why I think variations of the same layout are a very pragmatic way to demonstrate you can use this building for this need today, and this is how you would be using it in the future. There's yeah. Go ahead,
so it is if you like, to a certain extent, it's a battle I won't say I lose, but I always like to throw it out there. And it's what was it? Capital money is a tie. Sometimes someone would say it's non-existent. Therefore, Tobes, why can't you get your area down? Why can't you make it smaller? And we go through all of that, and the project managers say, "I've got a budget." Da, da, da. Whereas I sometimes then say, "But you shouldn't. You should try and strive to get the best that you can, get the biggest that you can, because it will cost you far more in the future to change and the disruption to existing services." And I think I saw a quote the other day. Actually, you're actually building something now at today's prices. You're not actually building something at tomorrow's prices. So it's just going to cost you shed loads more money in the future. And then there's other things that I always say to, if like the directors of finances, you shouldn't be ashamed to think about, yes, it's going to cost you more now, but just think about the savings you're going to do in the future, and the revenue consequences of doing that. So I'm just a massive fan of challenging, of that sort of that type of thing, and say, look, if you can build it now, or even do is it, what do you call it, white space, or space that you haven't fitted out, if you can do it, just do it.
Yeah, absolutely. So it all comes down to how I would say how teams communicate between each other. So if the finance teams that are sort of trying to drive the cost down can see the benefits, then that's what needs to be demonstrated, right? So if we can quantify the benefit somehow using that cost benefit analysis equation, then they might be able to understand the impact of flexibility and adaptability on their impact on the revenue cost, as Toby said, or their future capital spend.
The other one.
So Toby, you mentioned actually white space, which is one of the models we talked about as well offline, which is this sort of shell and core model. So this is something that is very typical in office spaces, but is not as typical in healthcare. So I think that's one of the ways you could address this sort of changing adaptable, flexible space, is to provide shell and core. And there's examples of that, like the Macmillan Cancer Center in Chesterfield, or the Evelina Center, Guy's and St. Thomas. So it's been tried and tested in the NHS. So model to look for. Alex, you were going to say something.
If you're referring to me, Alex, I was just looking at some of the chat that's going on LinkedIn Live between Dwayne and Andy. There's some quite interesting discussions going on over that side as well, which looking at the marginal costs of a building, and the kind of, I think the maybe slightly provocative question to kind of kick it off was, do we build buildings that last too long? Is there another solution to build with shorter lives in mind? And discussion between the marginal cost between 10, 20, 30 years versus maybe the more normal 60-year. Be interested to hear any comments and views you have around that, Toby.
I think that's, well, I was going to say, do we build buildings that are too long? But you just have to look. We only have to look at some of the ages of some of our estates at the moment, and it's, I mean, some of them are just going way past their life. So, I mean, we don't look after our estate anyway. And if my mate Dwayne Passman is on the call, and I don't know if he is, but he was the last gentleman to ever do any meaningful work at St Mary's Paddington. And St Mary's Paddington is a scheme that's been around for, well, it should have been redone over the last 40 years, and they've singly failed to do anything, or the support to do that. It's just completely failed. It's just going to fall apart, and therefore you've then got an estate that I mean, I'm never a huge fan of saying, is it fit for purpose? But, I always say, and this is where I start to challenge you, because we always talk about buildings, but actually it's the clinical driver. The building should fit around the clinical systems and the clinical needs of what we're trying to do. Therefore, if we've got an aging estate, it's not actually helping us do really good modern healthcare type stuff. And, does it lend itself to doing things like robotics and AI and all these other things? And it is actually starting to challenge ourselves to say, well, I guess you guys can create products and do things that allow the buildings to last, but it's just making sure that we keep that fabric going. And I think, so the other point was, you just have to look at things like the backlog maintenance on the programs that we're seeing at the moment on a lot of buildings. It's just horrendous. So we keep our buildings and we flog them to death and much longer, and it's purely because we don't invest in them enough. So if you guys can start, if you guys can actually create systems that allow us to do adaptable, flexible space that's constantly allowing us to evolve as we go along, because medicine and clinical technologies, it doesn't stand still. It changes daily. It's changing all the time, but our buildings don't. It's a bit of a political statement there, but it's there's plenty of project directors out there and colleagues that are just waiting to be given the money to get on with this. I better shut up, otherwise I get into trouble.
Good, thanks, Toby, and you spotted it. Yeah, absolutely, is your mate Dwayne who's asking these questions. So
good.
He seems to be alive and well.
We and it's not a brotherly loving, but we started within weeks of each other at North West Thames Regional Health Authority. So we've been through the system. We've got the scars on our back, and we've seen it all before. Yet there are a few of us, and we've been around that long to say he was the last person to ever do any meaningful work on that site. And that goes on. Anyway, sorry, mate. Yeah.
But it's interesting your comment though. We've seen it. I've seen it in some of our workspace projects. We recently did quite a large project with Google, one of their campuses in California. An entire building designed, kind of an office space designed for between 3,000 and 4,000 people. And there's hardly a built wall in the place. Everything is modular factory built construction. So that at any point, in the future, that building, I don't know what their expected life of the building is, but, say 50 to 75 years, at any point in the future, they can actually start dismantling walls, opening up spaces, maybe closing spaces into smaller. So you don't have to have this kind of toss up between, is it a 33 square meter room or a 16 square meter room? We can actually just dismantle the room and rebuild it over a weekend and turn it from one into the other. And then there's a huge sustainability impact of that, because you're not tearing down all the, the drywall and everything else and sending it off to landfill. You've actually got a big sustainability benefit.
And I guess there's also, for me, there's also something in all of this, which is around IT, the use of IT and digital technology. And when Shane said to me a few weeks ago, could I help out and do this, and I started to write things down, and it was, but where do we think it's actually in the title. It talks about transforming the estates, and it was in Shane's opening comments about changing the way we work, and that for me is massively important. And we should be challenging and asking the question, why do I bring patients onto an acute site? Why are we bringing everyone onto some of our city hospitals, our big district general hospitals, when we know that they're busy enough anyway? And we've seen, and even through some of the cohort, was it the Frontrunner 8 program projects, as they were called, or the cohort 2 stuff, a massive amount of things like outpatients now being saying, actually, we're going to drive this offsite. They don't need to come here. And I think Alex S picked it up earlier. Should we be doing them? What do you call it, Alex? Health in the high street. Are we going to start to see other types of facilities where we call them maybe sort of health, well-being and social care type spaces? Are we going to see this activity go? It's not going to go away. It's just maybe we're going to start to see it in different places. Are we going to start to see more the use of IT and connecting with patients digitally, that sort of thing? Although the only caveat against all that is then to say, but actually not everyone has access to IT, smartphones, that sort of thing, and that whole concept of digital poverty. And where does that go?
Yeah.
And where does that take us?
Sorry.
Yeah, sorry.
I mean, I think that That's a very good point you raised there. You know, those are the sort of the two models, the two sides of the estate strategy, right? You have on one side you're trying to plan for the long term and plan this facility which is future-proof, adaptable, flexible. But on the other side, you could say, well, let's take more of an opportunistic approach and see what existing spaces are out there, like Health on the High Street, and see how we could intelligently occupy them and deliver healthcare services which are closer to patients' homes. The argument about the argument about digital literacy is a valid one today, but will it be valid 10 years from now? And you know, the digital literacy is a curve that is sort of exponentially growing with every person buying a smartphone and so on. So it's definitely a trend that at the economic scale will be continuing growing for the next 20 to 30 years, sort of constantly. But just in terms of Health on the High Street, I think, again, this kind of flexible, adaptable space can sort of occupy these kind of generic, generic commercial spaces, retail spaces, and so on. And we've started to see examples of that. But I would also want to push the envelope a bit further. You know, why Health on the High Street is one level, but why not health in the downstairs deli, where you could just have like a pod, and you would have the patient sort of not even needing to go out of their building. And that's one of the main benefits of reducing travel time, is to reduce carbon as well. So care closer to home goes hand in hand with reducing carbon by traveling to a healthcare site. So if we can reduce travel as much as possible, that's two benefits. It's a win-win on both clinical and sustainability.
And in addition, you need less parking on the hospital sites. You can then start to impact on your overall real estate as well. Yeah, it's a great point.
But Alex, and some of these could be big numbers. So I've seen. I mean, it's not what I do, but I need the outputs and the results and things like activity modelling and demand modelling. But we've seen hospital trusts suggest anything up to, what was it? I would say it's a minimum, but it's like 35% of things like outpatient, some of their ambulatory work wouldn't take place on an acute site. What does that mean? Up to, I think the most aggressive I've seen is 50%. So, I mean, these could be really big numbers. So therefore, if you're saying some of that space could be done elsewhere, great. The activity and event doesn't go away, but it's just saying I'm doing it somewhere. But I'm actually then reducing what's coming in to an acute site. Does it meet the agenda of sort of the closer to home and that sort of thing as well? But equally, where we do use, and there's some stuff going on in the chat, which is great. It then actually says what sort of infrastructure do we need for IT and digital, and even on some of the early reviews that we did on the new hospital program, some of the sums, I think I'm allowed to say this, some trusts had some money in, other trusts had a huge amount of money in. The difference was phenomenal in terms of what people are going to invest into it to make this happen. So it's not a subject area that I'm well versed at, but I can appreciate and understand the importance of it. But it does demonstrate, you know, we've got to invest in the structure to make it work, and for the benefits to flow thereon.
Absolutely.
It's an interesting comment in the chat from Barty, who's commenting the bumping up virtual consultations with an aim to modify the space footprint, and we've done some interesting work with some of the. I know it's a controversial subject, but I think what we've seen is that it can allow the right activity to have more space with a view to the right activity, and not everything needs to go virtual. But some consultations are probably best done virtual, as Alex, as you were saying, in terms of carbon footprint. We did some work with one of the trusts in looking at reduction in lost school time, maybe for students with some kind of long-term conditions. So in the right application, it can really benefit that bigger overall spatial strategy. can't have
absolutely.
you reacted.
Absolutely. I mean, if there's a clinical need to do face-to-face consultation, that will always be there. Because it needs to be seen in person. You can't just, touch a person remotely. You need to do that face-to-face, right? But there is an important clinical trend, which is to bring care closer to home. And it's to provide individualized care. So over the next 50 years, we'll start to see many more technologies, products that will allow people to test themselves. So, for example, I've been doing finger prick tests for blood in my own home. Why do I need to go to see a GP and a phlebotomist to do that? I don't. Yeah, I prefer to stay at home and better use my time of day to spend time with my family or whatever. So that's a benefit to me. There's also all sorts of other things I could be doing in my own home. Older adults could be buying these kits, which do pressure testing, temperature, respiration, and so on. That could be linked to an online system, and you could be monitoring those patients constantly while they're in their home, where they have everything that they need, and they're not taking a hospital bed.
I can see in the chat, Bart has made a really good point about it, and it's sort of picking up on the sort of why do I travel in and the rest of it. And I think the comment there is about 40% of patients feel much worse due to traveling. And it just reminds me of that whole thing about why do you bring people in to a consultation exam room anyway? And if it's a case of, oh, all right, I've seen your bloods and I've seen that, great, you can go now. And it's like, well, you could have done that having sent some bloods in, or I guess a different arrangement, or done a, like we're doing now, consultation and saying, can we do virtual type stuff? And it's that whole thing of what it's asking that question, chat, why do you need to come in? Why am I bringing you in? And surely, look at just by looking at what we're doing now. I was not doing these sort of calls 4 or 5 years ago, pre-pandemic. And when we all had to learn how to do it, it was like, oh crumbs, another thing I've got to learn. But hey, I'm not too bad. I can do this now, and it's the world has changed. The world has changed dramatically in the last 3 to 4 years, and and I think we should start to make much more use of sort of technology and the like. And I mean, we've got a few minutes left, but it's that whole thing that, as Shane set the question about transforming healthcare estates. And one of the things that's really big for us, hopefully not going off topic, but it's to say, actually, what do we think a hospital or a health facility or any of the stuff that you architects as teams design the future, what does it mean in a post-pandemic world? What does a design look like? Who is to say that we're not going to have another pandemic, heaven forbid, touch wood, and we won't go down there? But we can't assume, or we can't say that we're not going. We've got to think about what would we do and what does that mean to us. So we have to start to implement all these sort of different ways of working, different ways of thinking into our designs for the future. I mean, that could take you down a whole new level of thinking there, Alex.
Yeah, I mean, thinking for the future in multiple scenarios is one way to kind of sort of resilience plan things, right? You want your facilities to be resilient to different changes and sort of respond to that dynamically. So, I mean, I would say, my closing point was more of an open question in terms of the future of healthcare estates. And it's something that I would like to ask all of you in the panel, but maybe also people from the estates teams in the audience. We're dealing here with a shrinking estate, aren't we? Because we're seeing less and less of a need for people to come in, as we just discussed. And we've seen the impact of net zero carbon, which is about keeping facilities that are not polluting, essentially. So I believe there's two models of how people can approach this. So it's either the anchor institution model, where you keep a lot of estates, but you make it work for you. It becomes a revenue source as well. And perhaps you host other smaller health organizations like primary care or so on in your premises. Or do you go for the lean estate model where you seek opportunities out there to lease space in retail stores and so on? So what do you think? What is the future? What does the future hold for healthcare estates?
So for me, Alex, it's and everything above applies. It's all those sort of things that you've just mentioned. So it's I think we will see, if you like, some of the acute hospitals, we could start to see them becoming much more in terms of high acuity patients. I think we will start to see, and it's happening already through a number of the projects we're seeing, some of the low acuity being driven off and being done elsewhere, closer to home. I think we will start to see more that health in the high street stuff. And there's, even the councils and other things that I've got colleagues talking to, they'll bite your arm off to help to introduce things in the high street, because for them it's a win-win situation. The whole thing about what is it, the declining high street and declining retail, and it for them it fills it up, it then gets bigger footfall, it makes it regeneration. Where's that going? Even what was it, the Health and Social Care Act, and it's a couple of years old, I'm not quite sure where that's got to, but we're supposed to be doing much more now and closer working with social services, local authorities. So is that another line that we haven't addressed and we're supposed to be doing in these facilities, to sort of the closer to home, quicker, faster? And it was in that get it right first time type documents, and the equivalent of what are we doing that was an acute stay and we were doing in beds that we now should be doing as day cases? What are we doing as day cases that we should now be doing as outpatients? What are we doing as outpatients we can be doing elsewhere? So it all cascades down, and I just think, and we do this every 10 years, and what is an acute hospital? And we all challenge ourselves and we go round and round, and we'll be doing this in another 10 years about saying, what are we taking onto an acute site? So I do think we will change, and I think some of the NHP program stuff has started to do that already, and I think we will see a change. That's where I just think we'll see the activity being done in different places, and I think the estate will respond to that, because and you would expect me to say this, it's the estate should be there to respond to the clinical driver, the clinicians and the clinical teams, and how we treat patients, and the clinical services, and the clinical strategies that are written by trust will be the driver. The estate has to respond to that, and I'll leave it there. That's for me.
Good, excellent, thanks, Toby. And I think I'd echo both your point as well. And if I look at this from being a patient point of view, in terms of if I want to get care, then the best option for me is either virtual or doing something close to my home, unless I need to go to that acute site. So definitely echo that, and I think we've seen that in some of the work we've done in how can we bring that care closer to home. And I think also, just going back on your point, reference to digital poverty, we've often seen with the clients we work, that does become a bit of a myth, and that most people can work with the new technologies and ways of working that we bring in. So thanks very much both for your insights. Just conscious we're coming to the end of time. Been a very insightful discussion, so thank you for everyone who's put in the questions as well. If there is further questions, then do pop them in the chat and we can always answer them after. But I think we are at time, so unless Alex, Toby, got any final thoughts, then I think that's a wrap.
No, it's good. I enjoyed that. That was super. Thanks for hosting that, Shane and Alex. Brilliant.
Well,
Good,
thank you as well. And Toby, it was great talking. And Shane, Alex, thank you for hosting. Great to see you all.
Bye, guys.
Likewise, many thanks.
Have a great afternoon.
Thanks, Alex.
Bye, guys.